Thank you, Jaime Esteli, for inviting me and giving a chance to speak in front of you. It is always interesting, Esteli. Yeah, it's and it's always a pleasure to have a crosstalk with physician. I tell you, everybody who's a super specialist, the first love is always medicine, and the kind of interesting discussion you were having with the nephrologist. I was reading that why didn't I become a neurologist and let nephrologist and let us continue with all those beautiful slides and working on. But today, what I'm going to present is a very simple case, zero contrast Chavi. The main thing what I want to focus is on aortic valve has always been a issue of contention between a surgeon and a cardiologist. So my take home will be two things. One, where a cardiologist should be involved, and second, the case which we did with practically no contrast. So this was a procedure we did along with my fellow Dr. Puneet. So first of all, severe aortic stenosis is a life-threatening and a rapidly progressing disease. After the onset of the symptoms, patient with severe aortic stenosis was survival rate as low as 50% at 2 years and 20% at 5 years. The partner trial demonstrated that 50% of the inoperable patient died 1 year without a valve replacement. It has got worse prognosis than many metastasis cancer, 5 year survival of breast cancer, lung cancer, prostate cancer, ovarian cancer, and severe inoperable aortic stenosis. You can see in this slide how much deadly disease we are treating. Why it has become important? As we see in the past, the life expectancy has increased, the economy has pushed, the patient now wants life that is beyond the usual 60, 70 years of the age. And that is why the focus is coming on the aortic stenosis. But there is a treatment gap. Risk of surgical valve replacement increases with age and comorbidity. 30-40% are deemed unsuitable for surgical aortic valve replacement. About 4.5 lakhs patients remain untreated, leading to about 80% mortality in 5 years. So there is a group of patients who are surgically ineligible and they have to be focused for the aortic stenosis and aortic valve replacement. This was the early confrontation. I will say when I started my cardiology around a decade back, this was the fight that we had with the cardiovascular surgeons. But almost now the fight has become so much reverse that the cardiovascular surgeons are now themselves going to learn TAVI because the procedure is so simple, easy, and for the patient, it is such a pleasure to walk away from the hospital 2 days without any major stitch and all. The standard option of treatment for a tight aortic stenosis can be 4. Medical treatment, balloon valvoplasty, surgical aortic valve replacement is the gold standard 50 years established line of treatment. We just can't take it out. Transcatheter aortic valve replacement, TAVI, whatever we call it. But here is the difference. This slide just tells what the work surgeon has to do on the right side with so many guys, so many wires. And this is a patient which we operate within next 3 years, he's able to mobilize. And this valve therapy is going on across the whole valves. Mitral, it is with the mitra clip and TER therapies, tricuspid, again with the clip therapies, and the pulmonary. The horizon is slowly and increasing, and in the last decade, the knowledge has become increasingly more there. This was the background. Around 21 years ago, this gentleman, Alain Trebier from the France, basically started this thing, and then there is a revolution. Revolution in such that now the cardiologist, the major practice has become a structural heart disease. Today, TAVR is becoming mainstream therapy. More than 1 million cases are done. 4.5 billion to 17 billion, the health estimate. It is expanding into lower risk and younger patient. Advanced THP version and driving the concept of heart team. Heart team means surgeon, anesthesia, the echocardiography guy, and the cardiologist coming all together in a particular case, deciding what is best and what is going forward. There is an evolution of evidence from inoperable from the partner and core valve trial, high to the partner and the cold valve, to the low risk. The data is now emerging and data is coming more and more. So the basic when the heart team comes, and that should be the first step whenever the aortic stenosis patient is there, that a proper heart team is there, a surgeon and cardiologist should be part of the parcel of the decision making. And that's a tough task in a place where both are having a huge practice and a huge ego, and where you are getting to get both of them into the things. So age 65 less, more bicuspid, activity higher. Generally, they go for the surgical wall replacement. 80 plus, tri-leaflet, low activity, they go for the tower. But if we go with the guidelines, and this is what the exact take-home message should be for the tower patient, when you should refer for the surgical and when you should refer for the surgical wall replacement. There are two prominent guidelines, European Society of Cardiology and the ACC guidelines. First of all, we should know if the patient has got palliative care. He has got severe comorbidities when the intervention is unlikely to improve quality of life or prolong survival more than 1 year. That is true for any procedure, even angioplasty or CABG. The patient should not go. If the life expectancy is less than 1 year, he should be on palliative care. This holds for any intervention, in particular for the TAVI also. Transfemoral TAVI, the European says age more than or equal to 75 years, all patients goes to the tower. Or high risk for surgical aortic wall replacement, 8%. I'm just quoting ESC because they are more advanced in this thing. The gray zone is when the age is 65 to 75, the intermediate risk for surgery, it is a gray zone. Patient can have either one. Why the tower has got a lag? Because the trials are around 8 to 10 years. We don't know how much the longer the duration the wall will behave. It is a bioprosthetic wall for the way other ways around. Surgical aortic wall replacement, age less than 75 years and low risk for SAVR. Also very important to understand. As a cardiologist, the guy who has got hammer will always look for the nail. It is not the things. If your relative is less than 75 years, he has got an active lifestyle, surgical aortic wall replacement should be the first target. Age less than 65 years, definitely there is no question about it that a surgical aortic wall replacement should be there. So this is nutshell what the referral for the surgical or the transcatheter aortic wall replacement there. Now coming to the case. So what are the challenges when we go for the tower? It is simpler to the surgical wall replacement, but the main problem with the cardiologist is we still rely on the dye. We have to use adequate around 100 to 150 ml of dye, which can be a nephrotoxic. All the nephrologists are sitting down here and becomes a real problem when we are focusing in this subgroup of the patient. So here was the gentleman, 72 years, diabetic, hypertensive, COAD, CA esophagus, post-radiotherapy, CKD on medical therapy. Presented with typical symptoms, dyspnea on exertion, class 3 and 4, hematuria. The labs, hemoglobin was 9.8. The CRAT was 4.2. Again, a big no-no for anything that is related to contrast. Echo showed severe aortic stenosis. Mean gradient was 54, aortic valve area less than 0.1, and normal biventricular function. Our team meeting was done. Surgeon himself said that TAVI should be the plan. Now the CT we did with the minimum contrast. These are the CT findings, and this is what the basic workup is what we require for a transcatheter aortic valve. In fact, now once we have the knowledge of structural heart has increased, we should also be getting all our patients who are going for aortic valve replacement also to go for the CT. We should understand whether the annulus is small. How much is the calcium? If the calcium score is more than 2000, the prognosis become different. So this is the initial what we did. Annulus measurement of, we did the area derived diameter and the perimeter derived, and we fixed our goal on 24.5 Merrill MyValve Octapro. The beauty about this valve is, I'm not promoting, but this is one Indian company. I tell you, last year I was in Milan for a fellowship for 3 months, and it was gladdening to see that Firangs were using 40 to 50% of the Indian valves down their shelf. And what an amazing moment that we are using a valve from the Indian company. So we had adequate sinus and STJ junctions were adequate. Calcium was not that much, 453. Bicuspid anatomy was there. The coronary heights were important. These are the parameters which we fix it even before we intervene. So how come the coronary and the structural, our engagement is different? In the structural, all the data is with us before we are going to the wall. Everything is planned, pre-planned as compared to the coronary intervention. The angle was favorable, and then what we did was, and you can see half-an-hour procedure in which a patient generally, if he had gone to surgical aortic valve replacement with all the comorbidities, how much time he would have taken. Two wires were put, one in the non-coronary cusp, other in the other cusp. Peri pacemaker was put in. A valve was taken, dilatation was done. Valve was positioned at the nadir of the aortic wall, inflated, and the results of the valve. Half hour, the procedure is completed. Next day, the patient is out. That is the beauty of the procedure. And all the data on the table. The left side is the gradient prior to the procedure. The right side is the post-hemodynamic trace. Absolutely no gradient across the wall. Slight bundle branch walk, but that is accepted part of the transcatheter aortic valve approach. So our is the next step, expanding indication, low risk patient, the data is coming, bicuspid, the data is coming, small annulus, any intra-annular valve, even our intra-annular or a surgical, it is a high risk. So small annulus is generally the field that is now going for the our asymptomatic patient, data is coming on and on. So with this, I end. I'm open to any questions which I may be able to. Thank you. Cost, sir, is around 15 to 25 lakhs, 15 for the Indian total cost procedure, 25 to the Western wall. But that's the early days. As the cost, the therapy is increasing, the cost will further drop down. That is for sure. It has been approved by TPA. It has been approved by CGHS. That is also the news. In fact, in some government schemes, say in Rajasthan, that Bhamashah scheme, they have approved the tower. So that is really coming down good on the part of that.
This for surgical aortic valve replacement over 8% now. That is a very calculator.
Yeah, STS risk is a calculator, sir. If you just get on the website or an app, you can get the things. So.
The cost predominantly is of surgical technique, or is it the?
No. The wall is around 12 to 13 lakhs. That is how the thing. Because it's a newer technology of patent, it has, because of the Indian companies now into the fray, it has come down, because once we started, that was around 7 to 8 years back, the cost used to be around 25 lakhs. As the Indian companies have come, the price has gone to 15 lakhs, but it will further reduce as the government comes and intervenes more and more. So, okay, so limitations of tower, there can be two ways. You are asking me the peri-procedure or post-procedure? Okay, so post-procedure, what the thing that hold down it is a bioprosthetic valve. As the surgical valves were mechanical and bioprosthetic. Bioprosthetic have got a lifespan. Now, why we are putting more than 75 years? Because the data is for initial was for 5 years. Now the data is for 10 years. Data is growing. There is a limitation that the bioprosthetic valve may degenerate, and you will require a second TAV, that is a tower in TAV. So that becomes a slightly difficult procedure as compared to the index one. That's the one. Second, the coronary access become an issue because your valve is sitting across the coronary. That is the second part. Third, there have been post-procedure, even to the month around, there have been the data of complete heart block. That is also one there. Then there was initial studies that there is a stagnation of blood, which can lead to thrombus, that can lead to strokes. Post-procedure, 1 month around the TAVI. So these are the limitations, but compared to surgical, these are minuscule. That is what I will say.
Is this running of
Yes. Yes, it is a synonym. That's it. It is done in the beating heart. In fact, once we are implanting the valve, what we do is we put, if you see that we had got that temporary pacemaker down here during this implantation of the valve. See, there is a right side, there is a temporary pacemaker. We get the heart rate to beat further because it will drop the pressures. Our fixing the valve will become much more easier. So it is in the beating heart. Patient, and by the way, patient is in conscious sedation. He's talking all the times. There is no need for GA. So all the GA and all those things goes off and on.
Yes, you kind of tell the depth of the valve just on the picture and the calcification.
Yes, calcification and sir, these two, the J-tip we had placed down initially. That is what the thing was.
placement of the wall without a contrast.
Yes, sir. That is what the whole thing was. So we require a contrast many times. There are two kinds of tower. One is self-expanding, and the other is balloon expand well. Here we had used a balloon expand well because in that, if the contrast load we require is less, because you go and implant and come it out. Here the challenge was that patient had creatinine was somewhere around 5, and he was on the risk of the zone of dialysis. So we said, why not go for the zero contrast? And the beauty of the procedure is hardly half an hour. You can see 4 5 slides, and the thing is on. Patient is back to the square.
The life of
At present, the data is somewhere around 8 to 10 years. We have got the whole data. Yes, sir.
So the important challenge in this case was to see the depth of the valve, because if the valve is too deep, you may have a higher chance of data block. So I'm sure only a very experienced operator can venture to do this type of atypical kind of thing. Because as you said, transfemoral, now get trans excel also. So there are alternate access. So some patients may not have good femoral, so we can do it in other access also. But obviously, that's a learning curve. But I think very nice. So thank you, Dr. Yabul.
Thank you, sir.
So most important thing which I think we should focus on is in young patients, we should not go for TAVI, because I have had patients who are 65 year females insisting on a TAVI. I said no, TAVI not for you, because as he said, although now with the latest generation, the longevity will probably increase even with surgical bioprosthetic valve. Now they claim 20-25 years of longevity. So similar kind of technique will also be available with us. But till the time those data is not there, it is unfair to send a very young patient to them.
Absolutely true. Absolutely.
Mitral valve also, people are doing mitral valve replacement. Usually it is done in bioprosthetic. Because a similar valve is used, but there is, it's probably doing higher.
So, sir, may I? So basically, valve itself is a huge different. Aortic valve is the simplest of all. It is gear and you have to cut. When you deal with the metal, the valve is bigger. There are cordies down there. So the challenge becomes much more. Valve replacement, as sir rightly said, is the one thing that is coming on the horizon. It will come on the big way round. The other thing is that once you have a mitral valve that is leaking, the leaflets are not properly opposing. What you do is you just put a clip. The two leaflets are less like a stapler, they are clipped on. The procedure is known as TER, transcatheter H2H repair, or Mitra clip, and very good. And I will say, mitral valve thing is excellent. The cost of the procedure somewhere ranges about sir. That is what I was last year for the Milan. That is a specific thing I was down there for. Mitral valve, sir, again, the approach is through the femoral vein side. We go through the right heart, we do a transeptal puncture, and we go to the left side. In fact, the procedure is much simpler in terms of complication than these kind of thing. It is more complex because the valve anatomy is different. So the traditional way won't lie, but the complication wise, the procedure, they are quite less. So very important question, sir. So what we do is once we come out with the TER device and we are out with the things, the wire is inside the things, the gradient is measured. Generally, the gradient is less and we keep it like that. But sometimes which happens without the mobilization, and we have seen on table that there the leak becomes too much. Or suppose a stitch has occurred, it has crossed to the outside the there. We put that because the wire is inside, it is 5 minutes job, put the device down there, ASD device, and we just close it down. But that is not a routine. Hardly 1% of the patient require that. And very exciting. And I will say the tower was around 10 years back. And now the things, the Mitra clip is the next 5 years, 6 years. As we have seen the change of the patients that are coming now, patients want to live more because now they are more financially viable, and somebody who's or say a doctor who is want to practice at 75, what is holding him back? He will go for that. And that is why these procedures are becoming more and more common.
This is a wonderful case, and I have a different from it was we got a Nisha. So in this age 75 plus, you have some positive fronts and EGFR is less, right? So there is a entity called contrastive nephropathy, and I think you gave those cases. Now, what is the current guidelines to give such cases of contrastive nephropathy?
So there is not a huge amount of data which says yes for the contrast related properties thing. But there's some amount of latest data which questions its existence, if at all. If all it is there or not, we do not know. It's if I have to look at how I practice, those patients who have comorbidities, like they have an CKD or they're diabetic or hypertension, elderly age group, those who are on metformin, ACE inhibitors, or SGLT2 inhibitors, in those situations, contrast has been associated with acute kidney injury. And mind you, I said associated. I don't know causation. So yes, I have seen that if I have to roughly enumerate what percentage, I would say 30%. That is why if at all a patient really needs a contrast, I don't say no. But of course, I do explain that these are the possibilities. Number two, I try to take off SGLT2 inhibitors, take off ACRBs if at all possible, optimize the patient, and then proceed. One thing which is definitely shown to decrease risk is maintaining euvolemia. So that is one thing. Apart from that, I'm not giving any other medication other than
Metformin is not indicated, but contrast is given.
so there is some data that taking it off 48 hours before the contrast may prevent occurrence of mobility.
Again, very rightly said by Dr. Asi. So the idea is as we do zero contrast targeting, so we do zero contrast angioplasty also. And the main idea is if a patient requires exposure to contrast, one should not refrain or one should not deprive that patient from that investigation. In fact, CT the contrast is intravenous contrast has almost negligible chances of intra-arterial contrast chances are higher. As you were saying, there have been studies both ways. Some say that it is just a myth. There is nothing like in contrast. But then we have seen patients going into renal compromise and they require one or two dialysis and then they come back. So hydration is very important. There should be UV. And there are studies that show that when you intervention measure the LVEDP and according to the LVEDP to reduce the patient, LVEDP guided hydration is probably the best. So just routine hydration also may not be very
There is a slightly related but unrelated topic that I also want to bring to notice. What about MRI contrast? Like whenever I say, so I get a patient for clearance for MRI contrast, I'm willing to give the clearance, but the radiology is not willing to do it. So MRI contrast in people who are less than 30 mils per minute of GFR is associated many years later with something called as nephrogenic systemic fibrosis. It does not cause acute kidney injury per se. If at all, it is an allergic reaction that might happen with paracetamol also. So with MR contrast specifically, if the GFR is more than 30, please go ahead with your study. If at all the patient is dialysis dependent, still you can do it because MRI contrast is dialysis. With CT contrast, dialysis does not do anything because if at all injury happens, it will happen instantly. We may dilate and remove the contrast, but it is of no benefit because the injury had to happen, has already happened.
MRI contrast and the CT contrast very identified. But what is about the low dose contrast that you be using this angioplasty? The idea is the dictum is if you keep the amount of contrast used less than the EGFR of the patient, then you may not injure the kidney too much. In fact, it's more than twice the EGFR, but we try. So we have now techniques as Dr. Dugo told. So we use intravascular sound to guide our procedure, and we do that ultra low contrast. So the only contrast that is used is during the angiography because you can't do an angiography without contrast. And subsequently, we use some techniques to kind of do the angioplasty without using any further contrast. And we have done cases where we have used 13 and 14 and contrast. It's something which now even the cardiologists there is a paradigm shift in the thought process that we use minimum amount of contrast. And I think that should be for any procedure. May not be somebody who is at high risk or who is intercomparable. For any patient, limiting the amount of contrast should be philosophy by the
I think the center also like conversely, easy on going of CKD patient pattern on 2.5 those symptoms, excellent results. No complication as per se. Previously, 5-10 years, we were very afraid of doing our these angiographies with pattern of 1.5 or 2. Now the thing that the change in practice and there is no casual contrast as well as from
As mentioning, the techniques have also
Yes.
less hydrogenated. Hydrogenated contrast types have also changed. So the situation is much better.
So-
there were cases where patient had multivessel disease or LP dysfunction. And probably the renal compromise is also partly because of the LP dysfunction. If you improve the cardiovascular this thing of the patient, the renal parameters also improve. So that fear should definitely go out of.
Generally, what we have seen across the contrast-induced nephropathy and why the results have improved, sir, we are now very clear with the offending agents. So suppose you are prepping up the patient with taking of the drug, as ma'am has said, SGLT2, ARNI. Patient is hydrated prior well to the procedure, and that becomes the only thing that prevents the contrast-induced nephropathy. That is the only thing, not any drug. That has become, the knowledge has increased, and with the newer device, as sir is saying, imaging and all, that has the contrast load has now in decrease. So as the understanding has increased, the CIN risk has increased. Second, more very important point, for any patient which we take for the lab, Behran score is one, again, online tool. Just put the CIN risk and show it to the patient. That also very important. Third, the question, since it's a crosstalk, I will ask Dr. Manisha, what we have got impression, the contrast that we give during CT and the contrast during the intracoronary. The intracoronary is more harmful. The reason why is that so?
Those patients who are undergoing coronary contrast have higher comorbidities. CT contrast patients are well optimized. Also, what all are the set of patients where you will advise CT contrast? Any which way your pre-test probability is different. So it's the comorbidities which are changing.
So why this question has come again to us is the structural things. Once our patient for the structural disease go for the same thing. He goes for the CT with contrast, he go the procedure with contrast. Definitely after the procedure with contrast, the rise is more. Probably also related to the hardware, the embolism, the shower going down to the kidney. That is also one thought process that comes to the mind. So yes, intervention contrast is really a challenge. Don't be in a rush for the patient, especially for the elective patients, the procedure, plan the procedure. That should be the dictum of the things.
Who take this topic? So the cholesterol emboli syndrome, which you're talking about. This we have faced more to the vascular surgeons, those who are doing peripheral angiography. And I have not personally seen many patients having this kind of issue with the CCU. But yes, the CTVS ICU does have this problem.
True, absolutely.
thank you, Dr. Rohit, and Dr.
Thank you, sir.
Thank you, sir. Thank you, Dr. for enlightening us about all these new techniques.
Thank you, sir.
Thank you very much. Thank you.
So and I now request we got our Bigupta was the first state our speaker. Because I think the third or fourth time that we will listening to excellent. Sir, like what I'm telling you. ये हमें दे सर आपको जाने तो बस This final 1 minute of you and your decision to announce the EDP is a what?
So how to save the brand, right? Next image पे कर लेते हैं. So any guesses from this slide that who is this person? This so many accolades and awards. So I think this month's no surprises. So this month's EDP Champion Award goes to our own Dr. Mitavi Doshi. Dr. Mitavi Doshi. So I will ask Dr. Mitavi Doshi to enumerate few things that you have done. I think in this year, this month's previous months.
Thank you so much to the EDPA, and this is like homecoming to me. I think the first meeting when this auditorium was built, I attended that first meeting, and it has been a regular feature of this. And I'm so happy that EDPA is such a vibrant community, and it is growing day in and day out. So few things that we have done. One is renal denervation, which we are doing quite regularly now. We started renal denervation when I was in Patparganj, when we did it with our own EP catheters. But now we have the specialized catheters from Medtronics. We are doing it, and we have got very gratifying result. In fact, this patient we did yesterday, her blood pressure was 180 by 110, and it was consistent, and she was on multiple medications. Today morning, her blood pressure is 90 by 60. We have to actually stop all our antihypertensive medications. Similar experience we had when we started in 2013. Dr. Alka Basheen had sent a patient to us from Max Saket, and we did the renal intervention. She was very particular that the patient should undergo a renal like dialysis. Those were dialysis patients. She was very particular that dialysis patient has to come back to her. She didn't want us to do dialysis at Patparganj. The next day there was a frantic call. You must have done something to this patient. The blood pressure is just low. So we said, what is the blood pressure? She said it's 120/80. She has never had blood pressure of this. You must have injured the vein, or there must be some hematoma or something. So what is the heart rate? The heart rate is 70. So I said, it's unlikely, but you get whatever. She got a CT scan and everything, and thankfully everything was fine. So it's a very gratifying procedure. Unfortunately, because of the way the Simplicity 3 trial was designed, it did not. But now it's a standard of care, and it is recommended for patients who are uncontrolled on 3 or more antihypertensive medications. Also indicated in patients who do not want to take or are not able to take the medication. Because in fact, the first patient we did with the newer device was, she was an old lady living alone, like not really alone, but there was nobody to take care of her, and she used to forget her medications. So when we used to give her in the hospital, the blood pressure was controlled, but then going back 5-6 medications, actually very difficult even for people like us to remember, and for a elderly person, it's very difficult. So we did the renal innovation in her case, and it was successful. So I think there are various patients where you can offer renal innovation to this. And so other thing that we did was what is called as Micra, the device that is the pacemaker, which is a leadless pacemaker. So it's a small, almost a capsule-sized device, which we implant right into the heart. So that's the upper one, and it's useful for patients who have higher risk of infections. In fact, it is very useful for patients who are on dialysis, because the patient has a fistula, and then you put a device here, and the fistula will not work. Many a time, patients have a fistula which has not worked, then you have got on the other side. So you really cannot choose the sides also. And in fact, one of our patient had a superior vena cava syndrome because of the fact that the SVC got obstructed because of the ICD lead. So this is a device which does make sense in these type of patients, especially who are on dialysis, who have infection, frail patients. And this was a very frail lady. So we did it, and it was a 15-minute job, just like Dr. Vibhuti showed the TAVI. So this was, in fact, small, quicker than that, and patient was very happy with that. And then other thing that we did was the high-end devices that we put. So the good point is, good thing about our country is we get the best of both worlds. So the best technology that is available anywhere in the world. Sometimes we get technologies which are not available in the US. We get it here because our FDA approval is not a necessity in our country. So there are things that are approved in Japan which are not approved in US. We get it here. Similarly, the reverse. There are things that are not available in Japan. We get it here. Drug coated balloons we have been using for years together. Now only they are getting approved in US. So there are new techniques that are coming up, and fortunately we are able to embrace these techniques and hope to do the best for the patients.
You did a good job as well, so without the question, and I request until the host to state he is the champion of the world. Productive host. That's this.